Okay, good morning. I would like to get started because we have a tight schedule today. All right. Okay. Good morning, Dean Lewis, faculty, students, family, and friends. I'm Dr. Brewington, assistant professor and coordinator of the Master's Project Sequence. And it is with great pleasure that I welcome you to the Department of Occupational Therapy's 2023 Annual Master's Project Presentation Day. I, for one, am very happy to have you all here today and to be back together in scholarship. This is our first in-person Master's Project Day since 2018. We're happy to be back together in one room live. And to everyone live streaming, I want to thank you for joining us this morning. Research evidence is essential to advance the knowledge related to occupation as a determinant of health and occupational therapy as an essential health service in every community. It is through evidence-based research that we are able to provide the best care, the most skilled interventions, and advance our profession. With Downstate being the only academic medical center in Brooklyn, we're in a unique position to bring together biomedical students, clinical researchers, and practitioners. Students and faculty in each health professional program are encouraged to pursue research opportunities. At SUNY Downstate Health Sciences University, our occupational therapy students complete a 4-semester master's project sequence in which they conduct extensive research in a variety of practice areas, all very pertinent to our profession. The students collaborate with their faculty research advisors, the community, and additional professional program participants to develop, conduct, and implement their research studies. This course sequence highlights Downstate's Occupational Therapy Department's commitment to the occupational therapy profession and evidence-based research. As the Master Sequence Coordinator, I'm looking forward to sharing with you all today the dedication and research from our OT students and faculty. In healthcare, research is the foundation for everything that we do. SUNY Downstate faculty and staff contribute daily to knowledge that shapes our world. So without further ado, I'm pleased to welcome our keynote speaker, the School of Health Professions Associate Dean, who is a national leader in occupational therapy, Dr. Bridget Desport. Dr. Desport's professional specialties are in early intervention and pediatrics with a concentration in the high-risk infant. She is board certified in pediatrics from the American Occupational Therapy Association, a certified assistive technology professional, and a board-certified telepractice specialist. Dr. Desport has a deep commitment to providing equity-centered care and services to the Black and Brown families she engages and works with in Manhattan and the Bronx. Her work also extends to Brooklyn, where she collaborates with neonatal analogist, and a pediatric neurologist at Downstate At-Risk's follow-up clinic. At the clinic, Dr. Desport monitors the development of babies who graduated from the NICU and supports their families through partnering and assisting with assessing resources and services. Dr. Desport's work also involves preparing students and mentoring OT practitioners to be equity-centered with providing services to oppressed communities. She does this through teaching, research, volunteerism, and as an advisor to student associations. Dr. Desport's research interests focus on the transition process of infants and their families from the NICU to home and equity-centered care to remove barriers to participation. Dr. Desport is the faculty advisor of the National Perinatal Association Student Society and the Black Students of Excellence. She was a prior board member for the National Perinatal Association and continues working with NPA as a member of the Discharge Preparation and Planning Steering Committee and Discharge Planning and Transitioning to Home Committee. Dr. Desport is a board member of the New York State Early Intervention Coordinating Council and an AOTA board director. As a member of the Discharge Preparation Planning Steering Committee, Dr. Desport collaboratively published the NICU Discharge Preparation and Transition Planning Guidelines and Recommendations in the Journal of Perinatology. Most recently, she published Uncovering the Obstacles, a typology of environmental and contextual factors affecting occupational participation, a scoping review, with two of her colleagues to define areas, categories, and terms not covered in the occupational therapy practice framework. Welcome, Dr. Desport.
Is this turned off? I don't want there to be an echo. Okay, thanks. I think it's just going to be too much movement, even though I'd rather move, but to try to sort this out in here. So good morning. How's everyone? Okay. So I was a relatively new OT when I attended one of my first IEP meetings. The school psychologist reported on the psychoeducational evaluation and findings of a child, and I just remember not hearing anything but, your child is deficient. She repeated this in every other sentence, your child is deficient. Somehow, it was the fault of the child, or perhaps the parent for why the student had no hope for capacity. I remember feeling distraught and traumatized by hearing that word, and I was not the parent. I looked at the other providers wondering, is this how we talk to families? And then I wondered, would the school psychologists have communicated in the same way had the parent been white? That is when my equity-centered focus began. From that day forward, I was going to empower those families who experienced powerlessness. DEI plus, I didn't coin that, someone at AOTA did, are important and necessary. I find that there is an emphasis placed on diversity and inclusion and not on equity and justice. I also witnessed that diversity and equity tend to be used interchangeably as if they are the same. Every so often I look up the definition of words to see the type of words chosen to define terms. It tells me a lot about the world. Can't touch the screen, can I? Yep. Yep. There we go. All righty. So the word, let's just talk about the word diversity. So the condition of having or being composed of differing elements, especially the inclusion of people of different races, cultures, et cetera, in a group or organization. So I just found the word condition interesting, which is why it is in blue. What does that mean? So to be clear, the word diverse is just another way of saying other. What are you diverse from or diverse of? Okay. The same concept of othering it applies here with the word inclusion. The act or practice of including and accommodating people who have historically been excluded as because of their race, gender, sexuality, or ability. I can be a room, it would apply that I'm considered diverse, and that I am included because I'm in a room with people who do not look like me. But does that mean that I'm being acknowledged, listened to, or that I have equity? So when we talk about being diverse from or diverse or included, this is the othering. So we, or me, I do not fall within these categories. Some of them, but not all of them. So, it is important that equity not be confused with equality. Equity is ownership, especially when considered as a right to share in future profits or appreciation in value. There is value in equity, equity in education, equity in property ownership, equity in the workplace, including pay, equity in resources, especially neighborhoods. Having equity equates to power. Those listed in this what's again considered the social norm, that's why it's in quotes, they can be considered obstacles to that equity. They might even be considered oppressors. So if you're like me, who does not fit in at least two of these categories, I am viewed as less than, and thereby have less equity. So in 2013, Dr. Leon Kirshner, back then I just called him Leon, approached me about a terminology that shifted the responsibility or simply blame away from the client, the families. We just completed a relatively large project, so I was not too keen on jumping into another one. And we were in a reflective phase at that point, trying to figure out, okay, what are we going to do next with this project? I told him to give me about another week to think about it, knowing that it would be a huge undertaking and a really lengthy project. Then a wise person, who shall remain nameless, was listening to our conversation and said, "You have to do this. This is you, Desport," and then told Leon that I would do it. I still told Leon I had to think about it, but I knew deep down I could not walk away from this project. This was an equity-centered project, and it was part of my work. So then Leon and I started to comb through the literature and began to build a body of terms. We presented our findings at the AOTA annual conference in 2014, and we received good feedback. Unfortunately, I had to step away from the project for a couple of years, but I promised Leon that I would return. And during that time, he found a potential collaborator. Her name is Dr. Nancy Doyle, and asked me if it was okay if she joined our project. Of course, I said yes. And then a few years later, the TECF was born. So the TECF is a combination of the ICF model, the capabilities model, and PEO. And there's just some language there just so that you have some references as to why and how it fits the TECF. It was developed from the review of 43 peer-reviewed articles, 2 book chapters that range from 1997 to 2020. It included the English language and publications from 12 countries. The result, 4 areas that the themes are related to context or environment, 12 categories, and 54 specific factors or terms. So before you ask, is the objective to replace the OTPF4? It is not. It is a supplement, some might want to call it a complement, to the OTPF. It fills in the gaps that are not addressed by the OTPF. That was the point. So to give you a little flavor of the TECF, I will talk a little bit about Area 2, social factors. The area of social factors is divided into 3 categories: social circumstances, attitudes, and communications. We're going to look a little closely at attitudes. Attitudes is defined as the perception of others towards abilities or disabilities of an individual or group. Then the terms that belong to this category are threats by others, stigmatization, stereotyping, marginalization, and discrimination. Note that these do not address the person. These define the context that are outside of the person. So I'll show you a little video, and I hope it plays. So basically the video is I don't know why it won't play. It's a really good video. Anyway, it's a boy that says, "Look at me and not my disability." So he's going down a street, and everybody's looking down at him, looking down at him as he's rolling through the street. And then the wheelchair shows up with nobody in it. It's empty, and it's just rolling on its own. And then eventually there's another boy who takes a basketball, throws it at him, and then throws it at this boy who's holding the basketball. So, as it's titled, the point is, "Look at me, not my disability." So rather than seeing this boy in a wheelchair that's not capable of playing basketball, how about we think about ways to have him participate in basketball, because he already knows and feels he's being marginalized and not given the opportunity to play basketball. Okay, so you see how it shifts it. Rather than say, well, let's find ways that we can adapt you or move or position you so that you can hold the basketball and thereby be able to shoot it in the hoop. So you see how that's different. And that tends to be our lens. There's nothing wrong with that. We're just saying, try to shift your focus. So how does the TECF relate to the work in the NICU that I do in the NICU, the follow-up clinic, and the transition to home? They are interconnected. So remember, my practice is equity-centered. So in the NICU environment, there tend to be more, the physical factors tend to be more applicable here. The environment, although we don't blame the infant per se for being born early, right? It's not their fault. There is an expectation for that infant to thrive in an environment that is artificial. It's not the womb. So these are the two categories, sensory qualities of the environment, and what falls under that, and there are more terms that fall under that, but the ones that apply to the NICU are cognitive, lighting, noise level, and smell. And then category C, sensory qualities of the environment, scheduling and time. I'm not going to go through all the definitions because I do have a limited amount of time, but I just wanted to share and just again give you more flavor of the TECF. The follow-up clinic. The area that tends to apply here is also social factors like it did for the boy in the wheelchair. In this instance, there is an expectation that the family has support when they transition to home, that they are somewhat have this social network, that they are prepared, but the preparation is incumbent on us, the providers, to make sure that they have the resources to be able to transition their babies to home, as well as feel confident to be able to care for their baby at home. These are the social factors that apply. So you see how there's a shift. The environment, it was more physical, and now that they're transitioning to home, it's more social. So social circumstances, support, social expectations, presence of a social network, the attitude, marginalization, category B, and then category C, communications, communicating that information, taking into account their reading level or literacy, and then the language, so offering information in a language that they use and that they're comfortable using. So in closing, I encourage you to, in your future professions as occupational therapists, to always presume capacity. People have unique abilities. Focus on being a facilitator to their participation. Create affirmative spaces and experiences for the people to whom you will provide services. Advocate in any way possible, and support a person's self-advocacy. Contribute to empowering those who experience powerlessness. I thank you for the special opportunity to share with you this important work.
Thank you. Thank you very much. So we're going to take a short 10-minute break.
Good morning. Oh my God. Today we will be presenting on our research study, Therapist Perspectives on Augmented Reality. I am Hazel Chow, and I am joined by my classmates Abigail Colton, Hannah Fetter, Amanda Puccio, Sabia Rahman, and Cecilia Tilson. Our advisor for this research study is Dr. Crystal Brewington. The introduction of smartphone-based augmented reality, AR, has revealed the ability to provide accessible and virtual intervention for individuals receiving telehealth or those requiring supplemental home treatment. While the current literature shows the popularity of augmented reality as a therapeutic modality, a notable gap is seen in documentation of therapist perspectives. This is an example of one barrier to the implementation of this modality in treatment. In order to understand why there is a lack of popularity in using AR as a therapeutic modality, we conducted a study where we sent out surveys to a population of OTs and their perspectives on AR. To understand the context of this study, it's essential to know the differences between augmented reality AR and virtual reality VR. AR enhances the user's real-world environment by adding computer-generated elements, such as images, sounds, and text, that can be interacted with in real time through a device like a smartphone or a tablet. In contrast, VR creates an entirely new environment for the user to interact with through a headset and controllers. With the rise of COVID-19, telehealth has become increasingly necessary, making AR an essential tool in rehabilitation. As AR can be used on smartphones and laptops, it is more accessible and realistic for a greater population.
Now I will discuss the research design of the study. This is an exploratory study analyzing occupational therapists' perspectives on the use or lack of AR as an intervention. For data collection and analysis, we used a mixed methods design to identify the hesitancies towards the use of AR as an intervention. The target population of the study includes the New York State Black Occupational Therapy Caucus, Motion Sports Medicine staff, and the Downstate Occupational Therapy staff. Participants were required to be registered and licensed and be actively working in the field, English speaking, or have the proficiency to read and complete the survey and provide consent. The primary investigator of the study, Dr. Crystal Brewington, sent the survey to members through listserv. Participants were asked to complete a short survey consisting of qualitative and quantitative questions on the use of augmented reality. This design assumed the responses to the survey reflected the honest opinions of the therapists contacted. So for this study, the data was collected through a survey of 25 questions that had been sent to 50 occupational therapists. Likert scale and open-ended questions were included in the survey and were accessed via a Qualtrics link that had been provided to the therapists. After giving consent, participants who provided their responses to be used in their research were allowed to remain anonymous. Excel was utilized to analyze the data from the Likert scale answers, and standard qualitative analyses have been used for the open-ended questions.
Okay, so from the survey we sent out, we had 27 occupational therapists respond. Of the respondents, 75% or 18 had not used AR, with only 25% or 6 having used AR. Of the 6 respondents that reported prior use, 25% have used AR often, 62.5% used it sometimes, and 12.5% used it rarely. Of the same population of AR users, we asked how effectively they thought AR was as an intervention method. The most common response was that AR was a moderately effective intervention method, which was selected by 88% of the group. 12% reported that it was slightly effective, and there are no reports of AR being very effective or not effective at all, demonstrating neutrality towards the intervention method. Regarding population, 30% of respondents used AR with the orthopedic population, 30% with neurological conditions, 23% with the geriatric population, and 15% in the pediatric population, demonstrating that use was not exclusive to one population. In terms of duration of use, 37.5% of respondents reported use for 6 months or more, 37.5% reported use between 1 and 3 months, and 25% reported that they have used AR for 3 to 6 months. Of the respondents who have not used AR, 43% somewhat likely to use AR in the future, 13% reported being extremely likely to use AR in the future, 13% reported being extremely unlikely to use AR in the future, and 26% reported that they're neither likely nor unlikely to use AR in the future. Of this same group, 55% of participants felt that they would be able to adequately instruct a client on the proper use of AR as a therapeutic modality, and 45% reported that they would not. Of the 55% who agreed that they would be able to use AR, they elaborated by saying that they were confident they could use AR after being properly trained or learn more about it. So this contributes to the argument of general usability of AR as an intervention.
Okay, here are some of the charts of our survey results. We can see from the pie chart above that only 25% of participants previously used AR, while 75% have not. The bar graph below shows that the participants that have used AR, most used it during in-person sessions, while fewer used it for a supplemental home program as well. Finally, most of those who haven't used AR reported that they do not think AR would compromise the quality of their interventions. Overall, out of 27 OTs surveyed, only 6 reported previous use of AR, while 18 had no prior use. Our analysis of quantitative data revealed that practitioners who had used AR found it moderately effective and were likely to use it again in the future, and those who had not used AR described hesitancies including technology competency and cost, but overall felt that the intervention would not interfere with the therapeutic process or therapeutic alliance.
Now we'll discuss some of the implications of these results of our survey. The results showed overall that there was a marked lack of knowledge from therapists on AR as a therapeutic intervention or as a modality at all. Similarly, most of the therapists could not differentiate between augmented reality, AR, and virtual reality, VR, and this was confirmed when most of the respondents who indicated use of AR had actually used VR. This is reflective of the need for further distinction to be provided between the two technologies so therapists can understand why AR can be more accessible. Our survey revealed that over half of the respondents felt confident that given the option, they could implement AR into a client's treatment plan and instruct them on proper use. This is indicative of the possible accessibility that AR holds as an intervention method and that it can be a realistic option for many clients. With that accessibility in mind, barriers like technology resources, lack of funding, and lack of client compliance were still identified as causes for hesitancy in implementation. Our primary takeaway from the data we collected was that the opinions of therapists are imperative to the continued development and improvement of AR systems. Since therapists are the ones prescribing, implementing, and evaluating progressive interventions, a collection of their perspective would suggest to technology companies that improvements based on the experience of these professionals can and should be made and would likely increase its use in therapeutic intervention.
Thank you for hearing our research study and interpreting our results that followed. Now that we have interpreted our results, let's discuss some limitations that followed from our study. First, our study did not reach our goal of 50 respondents. Rather, we had 27 respondents. From this small sample size, we can conclude that this may not be able to give a full representation of all OTs. Additionally, as prompted by the survey, some responses were based on prior use of VR systems, not AR. Further studies should seek to include a distinction between the two technologies in order to ensure validity of results. Lastly, some respondents did not follow the correct sequence of the study when prompted. For instance, a few respondents would state that they have not used AR, yet would respond to the questions directed at those who have used AR. As we can see, current literature was able to show us that there is a clear disparity between patient self-report and practitioner self-report, between the use and efficacy of AR as a therapeutic modality in OT. Our study aimed to investigate OT's perspective on the use of AR. Those who have not used AR did not use it primarily due to a lack of awareness, education, and resources, while our study does show that they are open to using it in the future. For the therapists that have used AR, it was shown to be effective and beneficial to the patient population and was applied in in-person settings and HEPs. Future research is needed showing efficacy of AR as a therapeutic modality in order to encourage future use and implementation. Here are our resources, references, and thank you for listening.
Hi all, welcome. My name is Leah Rischel, and I have the privilege to be presenting with my co-researchers here, Esther Friedman, Rachel Osayev, Shalamis Mammon, Natalie Manessa, and Shira Safia. The name of our research is the Impact of Occupational Therapy Curriculum on Students' Cultural Competence. We were led by our amazing faculty advisor, Dr. Nancy Klein, who we want to extend our greatest gratitude towards. Without her support, guidance, and direction throughout this entire process, we would not be standing here today. We'd also like to extend our gratitude towards Dr. Brewington for all of her support and advice throughout the entire master's project sequence. Finally, we would like to send a big thank you to all of our survey participants, the faculty, and the first-year students who are all here today. Thank you so much. Without the data from you guys, we would not have a research project. Keyboard. Okay, so we're going to start with a bit of an overview or the abstract of our research. So cultural competence, a crucial component in providing holistic client-centered care, is essential within occupational therapy. This study evaluated SUNY Downstate's Masters of Occupational Therapy's program ability to teach cultural competence. A pre-post test utilizing the Cultural Awareness Sensitivity Questionnaire was administered to the MSOT cohort of 2024, before and after the fall 2022 semester. An independent samples t-test was used to analyze whether there was a difference in cultural competence. The results showed no statistically significant changes in levels of cultural competence in any dimensions. Additionally, the faculty were surveyed, and results showed that the faculty lacked training in teaching cultural competence. Future research should focus on evaluating successful teaching methods for improving cultural competence within occupational therapy.
So some key points from our literature review that provide the background for the study is that, first of all, within the context of OT, cultural competence can be defined as the ability of a practitioner to understand their own limitations, to acknowledge their differences in worldview, and to develop interventions with knowledge, skill, and beliefs and attitudes in mind. Second of all, the AOTI emphasizes the DEI model, as we heard about from Dr. Despor this morning, for use within occupational therapy. So just a brief overview is that the model assumes that cultural competence can be achieved through recognizing diversity of individuals' backgrounds, that's the D, the need for equity of resources and opportunities, the E, and the I is the inclusion of individuals' diverse attributes and values. And finally, we found that cultural competence is a vital component of occupational therapy practice, as it emphasizes the profession's goal of client-centered treatment. Therefore, education in cultural competence will assist in training OT students on how to individualize treatment in accordance to each client's cultural, ethnic, and religious needs.
So we use the CASQ, and above is the first part, which looked at the students' perceptions of cultural awareness. So these are 10 statements where they were asked to rate them from 1 to 5, 5 being strongly agree. The second part of the CASQ looked at the students' perceived understanding and impact of cultural awareness. And here are the 5 questions that were asked, where they scaled them from 1 to 12, 12 being feel culturally competent.
Okay, regarding participants, 36 first-year MSOT students, 34 being female, 2 being male from various backgrounds, culture, and religion. 5 OT faculty members from the program participated as well. Regarding data collection, the first-year OT students completed a pre- and post-test of the CASQ at the start and the end of their first semester of the school year. Faculty members completed a survey via Qualtrics. Regarding the data analysis, the researchers of this study collected data from the pre- and post-test of the CASQ questionnaire. Students' total scores were recorded into SPSS for statistical analysis with an individual sample t-test. The faculty survey were quantitatively analyzed by looking at overall averages.
Okay, so moving into the results of the CASQ student survey, so we ended up having a 72.7 response rate for the pretest, which equated to 24 of the first-year students, and of those 24 students, 100% of them responded to the post-test. As Natalie mentioned, the responses were then analyzed using 3 independent sample t-tests. The first t-test compared the means of part 1 of the CASQ individually, the second comparing the means of part 2 individually, and the third comparing the combined means of the overall CASQ. And for all 3 of them, we set the significance value to p is less than 0.05, with values below that supporting our hypothesis of increased cultural awareness and sensitivity post the fall 2022 curriculum. So here's the first table of the results of our CASQ, and if you look at the first 2 rows, that indicates the descriptive data. For the first t-test, the analysis of part 1, we found that the means both pre and post-test were around 4, which according to the scale indicated that they agreed that cultural competence is an important part of occupational therapy practice. And then for part 2, we found that both pre and post-test, the means were around 7, which indicated that they were moderately competent in cultural competence. And then for the third t-test, the overall analysis was around 5, both pre and post-test. And the third row shows the results of the t-test with p-values on all 3 of them above the value of 0.05, which led us to reject our hypothesis. In terms of the faculty survey, these were the main results we found. As Natalie said, it was administered to 5 faculty members. All 5 of them did complete the full survey. And just to point out some of the key questions, for the first one, 60% of the faculty reported taking continuing education courses in cultural competence, while 40% reported that they did not. But of those, none of them reported taking courses specifically in educating students in cultural competence. And also we found that 50% reported that they somewhat often employ culturally competent behaviors when teaching, 25% pretty often, and 25% very often. And lastly, they reported that they feel that their students' performance students' cultural competence somewhat increases after their course, and 40% reported a bit of improvement.
So, based on the results, the MSOT's fall curriculum does not significantly improve the first-year OT students' level of cultural competence. So overall, the students performed similarly on both the pretest and the post-test of the CASQ with minimal deviation in means. So part 1 of the CASQ, students reported that they do agree that cultural competence is an important component of OT practice. In part 2 of the CASQ, students felt moderately confident in their personal level of competence, but as it got to the completion of the semester, there was no difference found in their reported confidence. The lack of significance found between the students' pretest and the post-test results may be due to the fact that none of the MSOT faculty have taken specific courses on educating students on cultural competence. It could also be that they incorporated this knowledge in the classroom setting by somewhat or a bit, as they reported. So what are our limitations in research? First of all, this data is not representative of our entire cohort, since only 24 out of the 33 individuals actually responded for filling out the CASQ. Second, it's impossible to control for other cultural activities that students may participate in their own time, such as by volunteering in the community. Third, we actually had a delay in sending out the pretest student survey since the IRB process took longer than anticipated. And then finally, a question on the CASQ referred to a fieldwork experience that the students have not yet experienced. So what are our next steps in future research? The clinical components of the MSOT program's curriculum can be analyzed in terms of how they impact the students' cultural competence. So we all know that fieldwork and community practice sequence can help students gain firsthand clinical experiences that will reinforce the cultural competence taught in the didactic curriculum. So perhaps analyzing the relationship between the didactic courses and clinicals will contribute to a more comprehensive understanding of the effectiveness of the curriculum design in regards to cultural competence. Also, perhaps educating the faculty regarding cultural competence through a DEI model may increase students' cultural competence.
So thank you for listening to our research and our limitations. In conclusion, the literature has proven the importance of having a culturally competent healthcare providers, as it is essential to decreasing the healthcare disparities within our healthcare system. As previously mentioned, the results of our study were not statistically significant, and the MSOT students did not display a statistically significant increase in cultural competence from their didactic portion of the fall 2022 semester. These results may be explained via analysis of the faculty survey, which indicated that the participating faculty did not receive any courses on educating students in cultural competence. So further research must be done to increase faculty training in teaching cultural competence and to explore the clinical and community experience of the students that may also have an impact on their cultural competence. So these are our references, and we thank you guys for listening to our presentation.
All right, good morning, OT family. How's everyone doing today? All right. You made it. All right, so my name is Dorian Valentine, and I am here today with my fellow Blue crew, Halem Go, Gloria Kong, Shui Pan. We will be presenting our master's project titled Examining the Impact of Social Media Competency of OT in Nursing Students, led by our esteemed advisor, Dr. Vikram Patton.
And we copy-paste Leia's thank you speech to thank Dr. Patton, Dr. Boynton, and our survey participant. Thank you.
All right, so in recent years, social media has become a virtual platform for our healthcare profession to facilitate networking opportunities and share health-related topics. This transition increasingly raises the need for both consideration and professionalism, as competency should also be considered in social media, as its usage is essential within any healthcare context. Cool. So here's a list of key terms that explores the realm of social media. These terms include social network identity, personal profile, digital professionalism, and social media competency.
So we found that the existing studies on social media competency of allied healthcare students are around following areas: knowledge of digital professionalism, ethics and practice in relation to social media usage, social media's role in enhancing health awareness for both students and patients, and the integration of social media in the academic curriculum. However, very limited research analyzes the similarities and differences between SMC in AI healthcare disciplines. So our study examined the social media competency of OT and nursing students at Downstate. The study investigated how the SMC usage impacted the academic and clinical performance. We also correlated both OT and nursing students' relationship to e-professionalism through quantitative research with the SMC scale. So what is social media competency? So it refers to an individual's capacity to use social media appropriately to send messages, engage with others, and encourage conversation and participation in the virtual community. The rapid development of social media culture, such as Facebook, Instagram, and Twitter, not only allows users to interact or self-present, either in real time or asynchronously with both broad and narrow audiences, but it has become an intricate component of individuals' personal and professional lives, as well as an outlet for disseminating, learning, and receiving information. This study was completed using a quantitative design. The SMC scale survey was digitalized using Qualtrics and was sent to all participants via Downstate email.
As you see on the slide presented, the study hypothesized that OT and nursing students within older age groups will demonstrate higher competency in professionalism, E-professionalism is same thing as digital professionalism that we were talking about. The study assumed all participants were either an active user or a spectator of contents within various social media platforms, including but not limited to Facebook, Instagram, Twitter, and YouTube. Some limitations of the study were that results obtained from the survey may not be generalized to the population of OT and nursing students, and the amount of clinical experiences and the year of matriculation varied by the participants.
Regarding the inclusion criteria, they must be current matriculated OT or nursing downstate students, own at least one social media account, and use it. So in our research, there are 47 OT and 45 nursing students, so almost half and half. We recruited OT students directly through Downstate email, and we are very pleased to have Professor Dr. Alice to help recruit the nursing students.
So a digitized social media competency scale survey, also known as the SMCS-CS survey, was used to collect quantitative data based on participants' social media competency. The self-reported survey took about 15 minutes to complete, and the responses were answered in strongly disagree, somewhat disagree, neutral, somewhat agree, or strongly agree. The survey composed of 34 items that were designed to measure each participant's ways of using social media, level of participation in social media, ability to access different features of social media, awareness of different features within social media, awareness of risks in using social media, and awareness of accuracy of the contents in social media. So this is the SMCS survey that we digitized using Qualtrics. And in fall 2022, the digitized SMCS survey was emailed to 190 matriculating downstate OT and nursing students. We collected survey responses for 6 weeks and sent reminder emails 3 weeks after the initial email. The collected responses were then organized in Microsoft Excel, and afterwards, descriptive data and further analysis of any correlations within age group, program, year of matriculation, and/or SMC scores were completed.
So the data collection process lasts 3 to 4 months. In fall 2022, the social media competency survey was emailed to 192 total participants, and 92 participants answered within 3 to 4 months of time frame. We did the data analysis based on survey answer and select some of them to present. First, the average MMC score of 2 programs. So we can see that the first-year nursing student has average of 3.6, and first-year OT student has average of 3.9, and second-year nursing student has average of 3.97, and second-year OT student has average of 4. We also look into questions that inquiries about participants' ability to evaluate legal and ethical principles of social media content, and we use Likert scale, where 1 is strongly disagree and 5 is strongly agree. And we compare nursing student age group 23 to 26 to nursing student age group 30 to 40. And same with OT student, we compare age group 23 to 26 versus 30 to 40. The result data is in the chart. We found out that nursing students in age 30 to 40 years old responded that they can evaluate legal and ethical principles of social media content better than the nursing student in the age group 23 to 26 years old. However, the OT students in the age group 23 to 26 years old reported that they can evaluate legal and ethical principles of social media content better than OT students in 30 to 40 years old. And we found out the study that both first-year and second-year students from OT program reported a higher number of MMC score compared to both first-year and second-year students from the nursing program. This result could correlate to the composition of the student from both programs. All students from OT programs are graduate students, whereas students from the nursing program are composed of undergraduate, graduate, and some doctorate students. The amount of year of study may contribute to the reported MMC score. Another contributing factor to this result may be students' age. As stated above, OT cohort has more students whose age is from 23 to 26, whereas nursing cohort has more students whose age range is from 30 to 40. Younger student population could be correlated to the reported competency to social media.
So, in conclusion, based on our research, the results of the study reject our hypothesis as the increasing popularity of social media usage of both nursing and OT programs have become more common. The purpose of this research studied future health professionals and their social media competency, and if it may have impacted their academic and clinical performance. Both programs have continued to develop an awareness of professional and ethical social media practice that would help in fulfilling their roles and abilities across experience, context, and time. All right. These are our references. Thank you so much for listening.
Okay, we are in front of the schedule, which is great because I thought we were running behind at first. We're going to now take a 20-minute break so you can view some of the posters if you have not. Use this opportunity to get refreshments and use the restroom. So 20 minutes. Thank you. Okay, we're going to continue. If everybody would take a seat.
Hello, everyone. My name is Victoria Kite, and I am so sorry that I can't be there in person with you all today. However, it is my privilege to introduce you to the Easy Does It Chronic Pain Program and to my wonderful classmates, Jane Sato, Nobuko Suma, Colleen Sims, Victoria Cagle, and Deborah Mulcahy. The Easy Does It program was led by our brilliant faculty advisor, Richard Sable, and it was run via Zoom and in collaboration with the Carpus Health Information Center at Mount Sinai. Now, for individuals experiencing chronic pain, Professor Sable led 8 90-minute sessions that incorporated education, proper body mechanics, breath work, and elements of Tai Chi, just to name a few. And our participants learned how to adapt their movements and activities in hopes of reducing their symptoms and increasing their participation and quality of life. I hope you enjoyed the presentation. Thank you.
All right. Yeah, a big shout out to Vi. We could not have done this project without her. We miss her very much.
Hello, everyone. My name is Victoria.
We miss her so much, we got to hear it one more time. Okay, so a little abstract. Chronic pain is persistent or recurring pain lasting over 3 months, which can occur due to many different diagnoses. The CDC estimates that 1 in 5 adults experience chronic pain in the US. Chronic pain can impact many aspects of an individual's life, including their independence and participation in activities of daily living, their ADLs, and instrumental activities of daily living, the IADLs. Occupational therapists have a unique framework in developing evidence-based interventions for individuals experiencing chronic pain. This quality assurance project demonstrated the efficacy of an occupational-based chronic pain program.
Next one is background. Living with chronic pain is harmful to an individual's quality of life and can precipitate disengagement from life's meaningful occupations. Chronic pain management programs and interventions that emphasize an increase in functioning result in participants reporting higher feeling of self-efficacy and greater quality of life even when a reduction of pain was not achieved. This highlights the efficacy of occupational therapy interventions that focus on increased functional performance as a variable component of chronic pain management. Occupational therapy practitioners help their clients restore, modify, and develop their capacity to participate in the occupation's roles and routines that they value. The occupational therapy profession possesses a unique and not yet fully realized ability to developed evidence-based interventions rooted in engagement and participation for those living with chronic pain.
The Easy Does It program was run via Zoom for 8 weeks. 7 older adults participated in the study. The occupational therapist, Professor Sable, led 8 90-minute sessions that incorporated education, body mechanics, breath work, core integration, balance work, and elements of Tai Chi. Participants learned how to adapt their movements based on pain levels to reduce symptoms and increase quality of life and social participation. Assessments were utilized in a pre-test, post-test survey design. The BPI was the brief pain inventory, that was an assessment that asked participants to rate their pain and its impact on mood, work, sleep, relationships, and life enjoyment. The PAS is the personal activities selection, was also used. Participants selected 2 meaningful activities impacted by chronic pain and rated their perceived performance and satisfaction for each. Participants also completed weekly check-ins to report their experience of that week's sessions, identify any improvements, and rate their current level of chronic pain. The data was analyzed through a paired samples t-test and descriptive statistics.
So as was just previously mentioned, our project utilized 3 assessments: the brief pain inventory, the personal activity selection, and weekly check-ins to derive our results. Beginning with the brief pain inventory, the average scores of 10 out of the 12 questions decreased from pre-test to post-test, including pain at its worst, pain at its least, average pain, current pain, as well as impact of pain on general activity, mood, work, relationships with other people, and enjoyment of life. This is displayed on the graph shown. Upon analysis, 3 of these proved to be significant differences before and after the program. Participants experienced a significant improvement in their average experience of pain after participating in the Easy Does It chronic pain program. Additionally, the impact of pain on participants' general activity significantly decreased after completing the program. And lastly, the impact of pain on participants' enjoyment of life significantly decreased as well after completing the program. Now I will discuss the results of the personal activity selection. Before beginning the program, each participant identified 2 meaningful activities that were negatively impacted by chronic pain. The personal activity selections were rated by participants before and after the study for perceived performance and satisfaction in the 2 activities chosen on a scale of 1 to 10, 1 being not performed well or not satisfied, and 10 being performed very well or very satisfied. The average perceived performance across participants for both activities increased from pre-test to post-test, from 4.86 to 6.5. Participants' average satisfaction for both activities increased from 4.29 to 7.14 on the 10-point scale. These results were both found to be statistically significant and are shown on the displayed graph here. And finally, I will discuss the results from the weekly check-ins. Each week, participants were asked to rate their pain on a scale from 1 to 10. Over the course of the 8 weeks, 4 participants saw a decrease in pain, 2 participants expressed that their pain stayed the same, and only 1 participant reported an increase in pain. Additionally, when asked, how beneficial did you feel this session was, 2 participants found each weekly session to be consistently very beneficial, and 3 participants showed a progressive increase from weeks 1 to 8 in how beneficial they perceived the sessions to be. Only 1 participant reported a decrease in how beneficial they found the sessions over the course of the program.
So management of pain is integral to social participation, activity performance, and satisfaction. Our small quality assurance study aimed to provide a telehealth program that would give pain relief to participants and address the effectiveness of integrating mindfulness and somatic practices into occupational therapy interventions for chronic pain. Our participants reported benefits and that they would love to continue the program or elements of the program if offered again. I just wanted to read some quotes from our participants. From one participant, I learned how easy it is for me to shift my body very slightly to achieve massive results. I found this very surprising. I learned that I can effectively help myself with pain from a seated position. This is new to me. I learned that pain can change or even go away. It is not as constant as I thought it was. It can get louder and softer. Another participant said, I learned my body has a choice. It can be led to believe that I need aspirin at 5 p.m. daily, or that it can skip thinking of taking anything and have a fluid day, only resorting to medication if there is actual pain or fatigue. This has made a deep impact on my life. I often am in the kitchen or standing to do chores and see that it's 6 or 7 p.m. at night, and I'm amazed with the capability of my body when I don't force it into a structure. A simple rethinking has resulted in an improvement that I can easily discern.
Okay, so in conclusion, occupational therapists have a unique perspective and are well equipped in creating interventions to treat individuals who experience chronic pain due to the widespread effects of chronic pain on an individual's ability to engage and be independent in ADLs and IADLs. Holistic and client-centered interventions have the potential to increase these individuals' quality of life. Based on the results of our study, we hope to see more research done on occupational therapy's role in chronic pain management. Are we taking questions? And these are our references. Questions? And we can take any questions at this time. And no? Okay, thank you.
Thank you very much. Can the next group please come up?
Hello, everybody. So our project is titled Assessing Emotional Intelligence in Occupational Therapy Students. My name is Kristen, and I worked on this project alongside my classmates Joanna, Michelle, Morgan, and Elaine, and we would like to sincerely thank our faculty advisor, Dr. Jasmine Thomas, who guided us along the way. So first, I'll just give a brief overview of our project. So this study assessed the efficacy of the Emotional Intelligence Curriculum, or EIC, developed by the SUNY Downstate Occupational Therapy Program. So what the Emotional Intelligence Curriculum entails is a variety of video vignettes depicting clinical scenarios, and they are followed by questions meant to inspire student reflection. So for this study, we developed pre- and post self-assessments to assess self-perceived changes in emotional intelligence in occupational therapy students before and after exposure to the emotional intelligence curriculum. In addition, a reflective survey was developed to gain more comprehensive data on the student experience. This data included student suggestions for ways to improve the self-assessments and the emotional intelligence curriculum in the future.
Here is a list of schools that currently utilize the emotional intelligence curriculum that was designed by SUNY Downstate students under the direct supervision of Dr. Thomas. So what is emotional intelligence? Emotional intelligence is a set of multidimensional soft skills relating to an individual's ability to distinguish, monitor, and gauge the sensations of those whom they provide treatment. It is the ability to understand the emotions of others and reflect on them. Emotional intelligence tends to improve patient outcomes and is a necessary tool that allows healthcare practitioners to develop rapport with patients and their families. Learning emotional intelligence in a curriculum that allows for student reflection on presented material has shown positive increases in students' knowledge of perceived emotional intelligence. The emotional intelligence curriculum, previously designed by SUNY Downstate students, contains video vignettes that significantly increase students' perception of the importance of emotional intelligence in fieldwork. Pre- and post-test assessments designed by our master project group were utilized and delivered to our cohort to give us an accurate snapshot of the effectiveness of the training curriculum.
Okay, so prior to conducting this study, we did a literature review, and we really focused on research studies involving assessments of emotional intelligence or soft skills in either healthcare workers or healthcare students. And these assessment tools from other studies really help to guide us in developing our own self-assessments for the purpose of this study.
So we identified 5 categories of emotional intelligence from the 6 video vignettes and from the literature to develop our pre- and post-assessments. And these are as follows: self-awareness. Increasing self-awareness enables better implementation of EI, understanding the emotion of others, improves quality of care, which tends to lead to better patient outcomes. responding to the emotions of others, a tangible outward response, facilitating client-centered care, delivery of care, how an OT delivers their service using interpersonal values to provide care, communication with other team members, contributes to positive work environments and motivation to work toward collaborative goals. Our study consisted of a convenient sample of 27 second-year Downstate MSOT students. Assessments that we created included a pre-self-assessment to be done prior to completing the EIC, a post-self-assessment to be done after completing the EIC, and a reflective survey which gauged participants' opinions of pre- and post-self-assessments. Participants were sent the assessments and reflective survey through emailed Google Forms links. The study used a mixed method design. We gathered quantitative data through Likert scaled statements and pre- and post-assessments and in the reflective survey. To gather qualitative data, we asked questions, open-ended questions through the post-assessment and the reflective survey. The responses for the pre- and post-assessments were analyzed using a paired t-test, and the reflective survey responses were analyzed using descriptive statistics. Short answer responses were then coded into general themes and taken into consideration for future recommendations and updates to the assessment.
For our results, we compared overall emotional intelligence scores from pre-exposure to the emotional intelligence curriculum to post-exposure. Unfortunately, we did not find any significant changes in overall scores. As you can see here, the mean for the pre-test was 4.01 and post-test was 4.06, demonstrating that participants on average rank themselves higher than average on emotional intelligence. We also included 5 open-ended questions on our self-assessment relating to the 5 categories of emotional intelligence. The responses to each of these questions fell into one of 3 groups. Participants either noticed improvements in perceived emotional intelligence, no changes, or they did not respond. So it's a little blurry. This chart just demonstrates those 3, the breakdown of those 3 categories, and suggests that there may have been improvements in emotional intelligence that the Likert-style questions did not pick up on. These are just some quotes from participants demonstrating improvements in their emotional intelligence. So one participant found that they were more aware of their body language. Another noticed improvements in their delivery of care and improved rapport with their clients. We also, as mentioned before, developed a reflective survey to gather more feedback on the assessments themselves, as well as the emotional intelligence curriculum. The most helpful information was the qualitative portion, where we gathered a lot of suggestions on the curriculum. So some suggestions on improving the curriculum are adding videos about cultural differences, such as hair and hygiene, including a potential video on sexual harassment, or also educating on how to navigate wearing masks and protective equipment around clients. So this graph here shows that our response rate to the reflective survey qualitative portion was very low, and we could have benefited from more respondents, and Michelle will talk a little bit about how we could have improved our response rate.
So as was previously mentioned, there were no significant differences found between pre to post self-assessment in our quantitative data. However, our qualitative results were able to provide more helpful feedback to the emotional intelligence curriculum. So students noted improvement in their overall emotional intelligence through these qualitative results. So this could indicate that the pre and post self-assessments didn't accurately measure the improvements in overall EI. It could also indicate that students might have rated themselves highly on the pre-assessment inaccurately. So this left little room for improvement from pre to post self-assessment. Future improvements can include making our Likert scale more sensitive to change, such as making it on a scale of 1 to 10, not 1 to 5. Another confounding variable was that this was a graded class, which could have affected participants rating themselves. And as noted before, we did have a low response rate on our short answer questions, so in the future we can consider making these mandatory. So future implications for the EIC, We can incorporate performance-based measures rather than self-report. So this could include fieldwork supervisors grading and providing feedback rather than self-report. So the feedback from the supervisor can provide helpful insight to the individual and help to improve overall emotional intelligence. We could implement cognitive interviewing, case studies, and role-playing in class. Also incorporate more video vignettes on a wider range of topics, such as cultural competency. Students noted that they would appreciate tips for self-reflection. And lastly, translations to the EIC can be incorporated for wider use. And before we open it up to questions, we just want to say a special thank you to our faculty advisor, Dr. Thomas. This project is a passion of hers, and we were so lucky and fortunate to be a part of it and potentially making better, competent future OT practitioners. Also, a huge thank you to our peer advisors, Dr. Brewington's group, Hazel, Amanda, Abby, Hannah, Cece, and Sabiha. Thank you for your helpful feedback. And of course, thank you to our master's project course instructor, Dr. Brewington, for following us throughout the course of these past 2 years in our master's project. And here are references, and thank you.
All right, hello. So our project is investigating the use of a pilot workshop for the inclusion of LGBTQIA+ content into occupational therapy curricula. I'm Sarah Davis. I use she, her pronouns.
I'm Julia Del Zingaro. I use she, her pronouns.
Xander Haber, they, them.
My name is Christina Ibokiti. I use she, her pronouns.
And my name is Sonja Joshi, and I also use she, her pronouns. All right, so before we go ahead and dive into our project, I wanted to give you guys a bit of context that illustrates the necessity for projects such as ours and research such as ours, and that aims to improve the health and well-being of the LGBTQIA+ population. And despite this being a growing community in the US, LGBTQIA individuals continue to face dire health disparities across the lifespan when compared to their cisgender and heterosexual counterparts. Some disparities that we found in our research was increased rates of mental health disorders, substance use, a lack of housing, increased rates of HIV infection, isolation as they age. So many of these disparities are connected to and exacerbated by the stigma and discrimination this population faces when accessing healthcare and in society as a whole. Some research has suggested that one way to possibly decrease these disparities is to better educate and train healthcare professionals like OTs to provide healthcare that is affirmative and inclusive to the LGBTQIA+ population. So currently there's no proven, consistent, and effective methodology to include LGBTQIA+ content into the curricula of OT programs. And as we know, the primary developers and facilitators of OT curricula are the faculty of these programs. So this brings me to the purpose of our master's project. We aim to pilot test the design and facilitation of a workshop program to explore whether such a program would increase educator competency and yield an effective template for LGBTQIA+ content inclusion into OT curricula. Essentially, we wanted to use this workshop to educate the educators of the OT program here at SUNY Downstate on foundational knowledge of LGBTQIA content and possible methods for including this content into their already pre-existing course curricula. Christina is now going to talk about our methods.
Okay, so to discuss the methods a little bit, we used a mixed methods research design consisting of a pre-workshop survey, an information gathering questionnaire, a workshop presentation, and concluded by the post-workshop survey and open-ended discussion questions. So this pre-workshop survey consisted of an 11-item Likert scale, and this was used to measure the participants' prior knowledge and competency in this content. Following that, we gave out an information gathering questionnaire, which was used to obtain demographic data and to get a little information on prior knowledge and teaching competence and practice. And then the workshop, which is the main meat of all of this, consisted of a PowerPoint presentation with 5 parts: the introduction, LGBTQIA+ health disparities, social determinants of health and stigma, understanding key concepts, obtaining resources, and the conclusion. Then we had the post-workshop survey, which consisted of the same Likert scale used as the pre-workshop survey in order to analyze the change in competency and knowledge after this workshop. And then we had open-ended discussion questions. They had 7 items, sort of to build up on the post-workshop survey. Okay, so these are the workshop survey questionnaires, which again was used before the workshop and after the workshop. And it consisted of 11 items, with 1 meaning strongly disagree and 5 meaning strongly agree. Some of the items included, I feel proficient in LGBTQIA plus terminology, the LGBTQIA plus population experiences disproportionate levels of stigma and discrimination, I feel knowledgeable to incorporate LGBTQIA plus content within my course curricula. Some other questions also included, there are barriers to including LGBTQIA plus content into my course curriculum. I know where to find resources for educational LGBTQIA plus content, and I feel comfortable, working with LGBTQIA plus clients. So following that, we did a little information gathering questionnaire. First part was demographics, which you didn't have to answer if you didn't want to. This is up to, the participants. So pronouns, gender, sex, orientation, and race or ethnicity. And then the second part was teaching and clinical practice, basically to get an idea of prior knowledge, teaching competence, and the practice. So it asks number of years in academia, numbers of teaching and clinical practice, area of OT practice, how would you describe your competency level in treating LGBTQIA plus patients and or clients? Have you ever taught LGBTQIA plus content within your course curricula? What do you hope to learn from this LGBTQIA plus health content training session? And what do you feel are the primary barriers to incorporating LGBTQIA plus content within OT courses? So now I'm going to hand it over to Sarah, who's going to talk a little bit about the workshop.
Yeah, so we're just giving you some of the slides just to show what our workshop consisted of, because we did a lot of things, so you're going to see them now. But on the top, the 2 slides, that's part of the presentation about LGBTQIA plus health disparities. So we talk about social determinants of health, types of stigma faced by this population. And then at the bottom is examples of 2 of the slides from our interactive portion that Christina nicely put together. And so we had a portion that was like true or false questions, and then we had a part that was more discussion-based. So things like, oh, what comes to mind when you hear the word sex, gender, or orientation?
So some more of the slide highlights. We went through basic terminology with the professors and faculty, things like sex and gender, how are they different, the definitions of those, orientation, the dimensions of orientation, pronouns, why they matter, both gendered and non-gendered pronouns, both older and neo pronouns or newer pronouns, and gender-affirming practices, other types of surgeries, chest bindings, things like that. And it's Sonja with more highlights.
So in this section of the workshop, we actually presented potential different methodologies to actually incorporate this content into course curricula. So one of the things we used was we showed short clinical videos and case studies that to kind of highlight, to tie into OT practice framework concepts. We had one video in the top, your left, one video depicting an interaction between a doctor and a trans patient, and it was coupled with questions about concepts like the instrumental activity of daily living, or IADL, health promotion, as well as occupational justice. Another video depicted the treatment for a rotator cuff injury, and we connected that to how such an injury would impact upper body dressing and safety for a trans man who may wear a chest binder. So essentially we were presenting these as like the professors can use these and put it into their courses, or to give them ideas of how to put them into these courses. And then we also had a case study presented of an older trans woman, and we connected that to how OTs would address her goals, like aging in place, while also considering the implications that come with her identity, such as possible social isolation and family estrangement. Julia's going to now continue describing the rest of our workshop.
The second case study we included focused on a university student named Alex who sought OT services for helping to feel more comfortable with transitioning in university. The OT gave Alex LGBTQIA plus focused resources such as the Association of Gay and Lesbian Psychiatrists. And then the last part of our workshop went into more depth about different LGBTQIA plus resources, and a packet of resources was handed to the participants. And then the middle bottom just shows a photo of the post-workshop open-ended discussion questions that we administered at the end of the workshop, with questions such as, What did you feel were the strengths of the workshop, and how can we improve the workshop to make it more relevant to the OT process?
Okay, so our results. So we had a small sample size as the nature of our study, since it was like a pilot workshop with faculty, so we only had a sample size of 3, and also due to time constraints, we could not do statistical analysis because that's like a really small sample size. So we have descriptive statistics, mostly looking at means of the pre-workshop survey versus the post-workshop survey. And I know it just has the item numbers on them, but for items 1, 2, 3, 5, 8, 9, and 10, the averages increased after the workshop, and most of those items, Christina had read them before, but they were focused on, like, is knowledge increased? Like, those were trying to see, like, if knowledge changed after. The ones that remained the same were items 4, 6, 7, and 11, and those ones were more of like attitudes, which would make sense that they would kind of stay the same from beginning to end, and they were also on the higher end, which is kind of representative of what's in the literature about how attitudes have changed towards this population.
So for the discussion, the results of this study show that this pilot workshop program was effective in increasing educator competence in LGBTQIA+ material. The changes between the pre-workshop survey and post-workshop survey demonstrate greater awareness and an increase in knowledge in LGBTQIA+ content and issues. Results were further strengthened by the responses to the post-workshop open-ended discussion questions. The open-ended questions showed increased interest, including LGBTQIA content, in the participants' curriculum. The particular lack of score change for item 6, which was I know ways to incorporate LGBTQIA+ content within my course's curriculum, indicates that a workshop more tailored towards each participant's curricula and more focused on their specific OT areas of practice may have produced better outcomes on this item.
So to just wrap it all up, this pilot workshop was effective in increasing basic knowledge and awareness of faculty participants on queer topics, providing inspiration to include queer content into the course curricula, and better equipping them to teach future OT practitioners to provide inclusive and equitable health care to the growing queer population. Limits include a small sample size as well as a limited amount of time. For future research, the workshop should include more OT-specific material, like the clinical vignette videos that depict interactions between an actual OT and a queer client. Having more time and more participants in this workshop would also yield a greater amount of data and results. Doing this would also provide a more direct method of inclusion into the pre-existing course curricula of an OT program like in Downstate. Special thanks to Professor Tribble and Dr. Brewington for their help on this project. Here's our references and any questions. No? All right, thank you.
Alrighty, we have one more presentation. Last but certainly not least.
Okay, so this is the article I did a critically appraised paper on. It was called Explicit and Implicit Disability Attitudes of Occupational and Physical Therapy Assistants. So some key terms to know that were in this study. Implicit bias, unconscious bias that results in automatic or unintentional feelings and behaviors towards people with disabilities. Explicit bias, conscious bias that results in overt and intentional feelings and behaviors towards people with disabilities. And ableism, which is assumptions that normal body and minds are the ideal, which promotes differential or unequal treatment of people because of actual or presumed non-typical functioning. So what are the effects of these biases and ableist beliefs in healthcare for people with disabilities? Biased referrals for care and clinical decision-making, and health disparities, which include lack of accessible or affordable transportation, lack of primary care services, less recreation and exercise opportunities, and systemic exclusion and discrimination. Okay, so measuring bias. To measure explicit bias, there are self-reports and surveys, questionnaires, or interviews. And to measure implicit bias, there's the implicit association test. So out of the few alternatives that are available, out of the few alternatives that are available to measure implicit bias, this test is regarded as the best and has been demonstrated to have high reliability and high validity. But this test also is not a perfect tool. With that being said, it can have high rates of false positives. This is because the test can't distinguish between test takers' general awareness of bias or cultural stereotypes versus true personal prejudice. So what are the gaps in the literature? Research in OT has focused mainly on explicit bias, and why is this a problem? This is a problem because studies have not looked at the interaction of implicit and explicit bias and how they both may impact rehabilitative care. Additionally, having explicit bias does not necessarily mean someone will be implicitly biased as well, and vice versa. So some other terms that are important in regards to this article: truly low prejudiced, low explicit and implicit prejudice towards people with disabilities, symbolic ableist, high levels of implicit and explicit disability attitudes, principled conservative, high explicit and low implicit bias towards people with disabilities, and aversive ableist, low explicit and high implicit biases. So yeah, using a two-dimensional model for implicit and explicit biases, they can be measured independently. So yeah, as a result, these are the 4 categories of prejudice. So the purpose of this study, the aim of this study was to explore the disability attitudes of occupational therapy assistants and physical therapy assistants. This study's primary research aim was to quantify their explicit and implicit attitudes towards people with disabilities and categorize these attitudes using a two-dimensional model of prejudice style. So this study was a secondary data analysis of disability attitudes, implicit association test, DA-IAT. And yeah, using the two-dimensional model, implicit and explicit biases were measured independently, as I said previously. And so the DA-IATA is specifically for disability attitudes, but what is this? It's a computerized measure which presents participants with target concept discrimination of disabled persons and abled persons, and with attribute dimensions of good and bad, ask them to select word and symbol stimuli accordingly. Secondary disability attitude data was retrieved from Project Implicit. And Project Implicit is a database where people voluntarily choose to test their prejudices. So out of the 6,113 occupational therapy assistants and physical therapy assistants who tested between this 16-year period, nearly 85% of the participants were women, nearly 75% were white, and the average age of participants was 27, and only 10% of the participants identified as people with disabilities. Okay, so this is figure 1. There are 3 figures. So the findings revealed that most OTA and PTAs reported no explicit preference for people with or without disabilities, and the overwhelming majority were implicitly prejudiced against people with disabilities. The majority of OTAs and PTAs were aversive ableists, which is low explicit attitudes and high implicit attitudes, indicating they reported and or believed that they had little disability prejudice, yet held negative attitudes about people with disabilities. So yeah, this figure right here shows that there was 68.7%, right in the middle there, which was the majority, expressed no preference between people with disabilities or non-disabled people. 8.2% strongly preferred non-disabled people, where 6.4% moderately and 1.8% strongly preferred non-disabled people, respectively. And less than 5% of the participants preferred people with disabilities, with 0.6 strong, 1.3 moderate, and 3.0 slight preference ratings. Okay, so this is figure 2 of OTA and PTA implicit attitudes. A majority of OTA and PTA implicit attitudes strongly preferred non-disabled people. Nearly a quarter of participants, 24.7, moderately preferred non-disabled people, while 13.3 had a slight preference for non-disabled people, with 12.3% having no preference, and just over 8% of participants preferred people with disabilities, with 1% having a strong preference, 2.8% having a moderate preference, and 4.1 having a slight preference. And there's another figure that is visible on the poster board outside. I couldn't get it on the PowerPoint, but figure 3 is a two-dimensional prejudice, talks about two-dimensional prejudice categories. So 60% were aversive ableists, so low explicit but high implicit bias. 31.6 were truly low prejudice, so low explicit and low implicit biases. And 6.8 were symbolic ableists, high explicit and high implicit bias. And 1.5% were principled conservative, so high explicit and low implicit bias. All right, so the discussion, how to help future clinicians. So I have here disability simulations with a question mark. So what are these simulations? It's role-playing the experiences of having a disability, unintentional reinforcement of negative attitudes towards disability has been shown, though, during these professional trainings. And these simulations have increasingly been critiqued for distorting the reality of living with a disability, reproducing stereotypes that disability is related to incompetence and dependency of the person, and failing to contextualize the lived experience of disability from the perspectives of people with disability themselves. Many studies outside rehabilitation have shown that disability simulation produces more negative attitudes towards disability. So what has been shown to work? Engagement with people with disabilities, and this can include bringing people with disabilities into an academic setting and as faculty or as guest lecturers, and advocacy. So advocacy efforts can include education on social and relational models of disability, in addition to focus on how policies and practices function to maintain stereotypes, prejudices, and internalized negative attitudes of disability. So what were the limitations from this study? The study itself reported a possible selection bias as a limitation. Follow-ups with participants, from 2004 to all the way to 2020, those follow-ups couldn't take place since the analysis of the data used was secondary data. And since the data was collected from this 16-year period, the differences in the educational curriculum through the years could not be accounted for, or whether or not the years, the implicit bias and explicit bias had increased or decreased within test takers. That's it. Thanks.
Thank you all. You guys did wonderful. Now we'll have our chair, Dr. Noir, with some closing remarks.
All right. You did it, huh? Please, let's have another round of applause for our graduating class. That's right. Thanks to you, Dr. Brewington, and to each of the faculty advisors for all your efforts in helping these students prepare for this day. And I don't see her, but big thanks to Alethea for her very visible and behind-the-scenes support in making this day a seamless one that is fitting for all the talent and industriousness in this room. To our graduating class, over the course of the last 4 semesters, you've been engaged in a process of inquiry. From conducting a literature review and developing a proposal, to collecting and analyzing information on your topic, to sharing your findings with your peers, so that this information can be applied to improve our educational and clinical practices. Regarding of which career path you decide to take from here, this act of inquiry that you have just completed has implications to your day-to-day work as an occupational therapist and for your personal lives more broadly. Inquiry is the act of seeking information, making discoveries, and testing those new discoveries for new understanding. You have been making inquiries since you were a newborn playing peekaboo. And feel free to correct me if you remember your cognitive milestones better than I do at this point. Now you are much more familiar with a formalized process of inquiry. Over the years, you will use this process to ensure that you maintain your professional competence, to be ethical and evidence-based in your delivery of occupational therapy services, and to add to the body of knowledge that continues to advance what we know about occupation and the implementation of that to improve the health and participation of the clients that we serve. By completing your master's project, you have demonstrated the basic skills in conducting formal inquiries, skills that will serve as the foundation for high-quality occupational therapy practice, a career in inquiry. In 2015, at the 95th Annual Occupational Therapy Conference that was held in Nashville, Tennessee, Dr. Helen S. Cohen, now a professor at Baylor College of Medicine in Houston, Texas, gave her Eleanor Clark-Slagle lecture on this very idea. I often share the transcript of this speech within my courses to feed curiosity, and I encourage you to go read it, A Career in Inquiry. And the power that inquiry has, not only as an occupation, but also to the evolution of the human mind. A career in inquiry is being courageous. It means being brave enough to ask questions in the face of authority figures or the status quo, no matter how silly or profound you think those questions may be. A career in inquiry means taking chances and challenging ideas, even when those around you have accepted their fate. You have the tools now to build on a career of inquiry, and the choice is now fully within your control. Deciding on a career in inquiry means developing the identity of a scholarly practitioner. This is an occupational therapist or occupational therapy assistant who demonstrates a lifelong commitment to the excellence in practice through continuous learning, evidence-based decision-making, and translating knowledge into practice, and using their practical knowledge to inform scholarship. This is what you are becoming. And it is a wonder to see that before my very eyes. So congratulations on achieving this milestone and nearing the completion of the didactic portion of this program. Level 2 fieldwork is up next, and that will be a perfect time to apply your inquiry skills. So stay courageous, keep asking questions, and keep being curious. Thank you.
So that concludes today's master's presentation. Thank you very much. If you don't mind, if you haven't seen some of the posters, they're all in the atrium. Please view them, ask any questions to the presenters, and thank you. Let's have a group picture before you guys leave, all the presenters on stage if possible. Thank you.